probably the answer?
Well, I think the answer is complex, and I think Andre has illustrated to you how complex it is. So I was asked to talk about destination therapy in the UK, and we're fighting for it for quite some time, and I try to put a few things together to give you my view on this. So I think there's no doubt, absolutely no doubt, and you won't find even the strongest opponents of this, that mechanical circulatory support saves lives and improves quality of life. There's no doubt about it. So the answer basically to the question about destination therapy for the UK can only be yes. I could stop here, literally. This would be my talk. But it's a bit more complex than that, so let me just take you through a few other things. Obviously, because mechanical circulatory support is so successful, and there has been a development of a concept for the treatment of advanced heart failure. And we moved away from the issue, everybody who has advanced heart failure needs a transplant and will get a transplant. It's not happening. So because of the huge effectiveness of mechanical circulatory support, we have been able to develop this very sophisticated concept. So we can use them as a bridge, as we just heard. We can use them as a sole therapy. We can combine them with other stuff, cell therapy or whatever, and by default we have discovered that actually some of the hearts recover. That goes up to 20% of the cases, which is quite huge, because in the old days we used to take their hearts out and they had to undergo heart transplantation completely unnecessarily. So this is all based on the background of the concept of mechanical circulatory support. So great achievement. So the concept as such, as to use it without heart transplantation, has been introduced by the so-called rematch trial at the beginning of 2001. So this was the first prospective randomized trial. It's quite difficult to randomize actually patients versus, best medical therapy versus devices. Even in those days it was difficult. It was done in the US, which is even more difficult. But it was the first prospective randomized trial that paved the way for the application, for the broad application of MCS. So it's a huge trial for us. But despite the fact that this has been adopted all over the world, in the UK, this successful therapy has been denied for eligible patients until today. So we can't do it. This is just a reminder of the New England Journal of Medicine article, and this is the first slide, which shows the survival difference. It was not overall, it was not great, but at least you could see a huge difference between best medical therapy and circulatory support. And they've updated it after they used a more modern device, which was the HeartMate 2, smaller, less aggressive, smaller surgical trauma, and the results were even better, going up to a 2-year survival of close to 60%. Amazing for this high-risk group of patients. So, and recent trials, and this is one of the most recent one, and it has been achieved with a very sophisticated pump, is the advanced trial comparing two sophisticated pumps, and you can see it's an incredible 3-year survival of around about 90%. And it is about survival, and I completely disagree with Andre. It is about survival in the first place, because that's what we deal with. So this is the advanced trial-based pump, which has been used at a time, which is called the HVAD from hardware. So what's this UK situation at the moment? We've got nearly 1 million patients suffering from heart failure. The mortality in the UK, being in class 4 heart failure, is 70%, including a high risk of sudden death. I think that's universal. That's not specifically the case for the UK. And obviously the prognosis of this stage of heart failure is worse than breast cancer and prostate cancer. But nevertheless, we spend much more money for both breast cancer and prostate cancer. So, to carry on with the situation in the UK, this life-saving therapy is not available in the UK. And it has been pointed out already before, we had a 2/3 drop of heart transplants in 1995. In 1995, the number of heart transplants in this country was 350. In 2011, it was 100. So an amazing drop. By the same token, we do only 60 to maximum 80 LVADs for the whole country. So this is about 1 in 10 million, as opposed to Germany, where the annual implantation of long-term LVADs is 11 to 1200. So a 10 times as many LVAD implantation rate. This is because of rigorous restriction, which is imposed on us, not based on medical decision. This is a simple regulatory pressure. As simple as that. No medical reason. For example, the funding stops 12 months after implantation, because those who give us the money anticipate that every patient will be transplanted after 12 months, which is like, in the old socialistic Eastern Bloc thinking. You say, okay, this is what it is, and then it happens. But it doesn't happen. So they stop funding after 12 months. And the other restriction in this country, which is unbelievable for these devices, is that only 6 centers are allowed to provide mechanical circulatory support in general. And Professor Westerby has alluded to this already, what sort of problem this can cause. So what sort of patients are we talking about destination therapy? We have to define patients. Not everyone is a destination therapy patient. And we're not aiming, those who are making the decisions, Andre, myself and others, and David, we're not aiming for the usually morbid patient. We're not aiming for the 85-year-old with all sorts of comorbidity to treat his heart failure. We're aiming for those who are basically on the border of being good, acceptable transplant candidates. And for those where we know already in the past, where there was no mechanical support, that they don't do very well with a heart transplant. They suffer for morbidity due to medication, etc. So we're aiming for a certain group of patients which is not that much out of the range. I'll give you a few examples to lead you through that, where we are coming from in Newcastle. So this is a typical example, I would say, is fundamentally a destination therapy. So a gentleman, 67 years of age, had acute MI, very regular, happens to all of you on the weekend, no problem. Went into cardiogenic shock after failed balloon angioplasty, had intra-aortic balloon, inotropes, went into renal failure, CVVH, no recovery after 2 weeks. So most of you working in regular cardiac centers would give up. You would say, that's it. So I looked at this gentleman and I said, well, that's what we're here for, we save lives. So we took him to theatre and we put an LVAD in. He was discharged home 4 weeks later without any problems. And since then, he's at home. So more than 4 years on the device, absolutely limited amount of complications. And surprisingly, he doesn't want to transplant. He said, why would I go for a transplant? He's now close to 72. So why, for God's sake, would I go for a transplant? And he's quite right. There's no good reason to do that. So by default, and in that respect, I agree with Andre, this is destination therapy. We were not allowed to say that, because otherwise we wouldn't get any money, but this is what it is. Anyway, so this is case number 1. Case number 2, youngish man who was assessed for transplant very poorly, not very well, after acute MI, ischemic cardiomyopathy, right heart catheter, showed severely elevated transpulmonary gradient. So clearly not a transplant candidate. So according to the textbook, in this country, we would have pulled the plug. We would have let him die. But we didn't, because we followed the concept, which wasn't based on our research, but on others, saying, if you put a left ventricular assist device in this gentleman, you will be able to lower his TPG, and you will turn him into a transplantable candidate. And that's what we did. And as you can see, on repeat right heart catheters over the time, his transpulmonary gradient came down to a level where he could be transplanted. And then now, he is on the active list, transpulmonary gradient becomes low, and this is him. This is not Deep Purple, but he looks like Roger Glover from Deep Purple, you might notice. So he's an active band member of this group, and he leads a very active lifestyle. So, patient number 3, a similar, very average case, which you notice shortly. 66-year-old gentleman, acute MI, cardiac arrest, had this actually at another hospital. That makes this case so interesting, and this will lead to the discussion we'll have later on. He had a PCI, failed, and went into cardiogenic shock. And our colleagues in Leeds Hospital, they did what everybody else would do. They put balloon pump in, inotropes, etc., etc. Squeeze the screws. Didn't get better, rather got worse. Got intubated, ventilated, poor. Then we had conversations on the phone, and they transported the patient to us. He was not very well, I have to say. In hindsight, probably next time we would do it with a different concept, but this is what we did at the time. And he was very poorly when he came, renal failure, liver had taken a hit before, so I put a VA ECMO in in the middle of the night, and basically the concept this time was a bridge to decision or to candidacy, because I didn't know anything about this patient. I didn't know about his neurological status. I didn't know whether he would ever recover from his respiratory failure. I didn't know much about this patient. So normally, according to textbook in this country, we should have not have done this. Okay? So then we did some investigation. Transesophageal echocardiogram showed on top of his LV dysfunction, moderate aortic regurgitation, etc., etc. Anyway, he recovered on the ECMO. He had a bit of ischemic brain injury, probably when he had an arrest or something at the time. But he had complete neurological recovery. He was extubated, ECMO, etc., etc. And after a couple of weeks, we put an LVAD in. He had other complications. It took him quite some time to recover, but he was discharged home and recovered and is now on the transplant list. So this is also a case where I would say in hindsight, you could put this terminology destination on this gentleman, and it's completely irrelevant which tag is on his forehead, whether it's bridge to transplantation or whether it's bridge to destination therapy, because at some stage he might get the transplant, or he is so well that he doesn't need a transplant. So, but where do we get solid information about this question? Is destination therapy a good thing to do? The only registry in the world which is collecting good data is the so-called INTERMAX registry at this point in time. There's nothing comparable. There will be by the International Society for Heart and Lung Transplantation, but the INTERMAX, based in the US, collecting all their data, is the most reliable at the moment. So let's see what they can tell us about the question of destination therapy. So they have a huge number of data. Over the years, between 2006 and today, they have collected more than 7,000 patients. It's about 150 hospitals contributing. It's across the board, everything. But it's only durable devices, so they're not looking at short-term devices. Durable, longer-term devices. And as you can see on this one, the red column shows you it's mainly now, almost exclusively, continuous flow pumps implanted. Interestingly enough, if you look at the subgroups, there's quite a substantial number of patients on destination therapy. And it's increasing, as you can see. In 2012, 44% were classified as destination therapy. So quite a remarkable increase. And if you look at the results, they're actually not bad. If you look at this one, this is the result of overall of the whole series. And the survival is 80% at 12 months, 70% at 2 years, and then 61% at 3 years. Quite remarkably well. This is for the whole cohort. If you look at if you break those up in between continuous and pulsatile flow, you can see the difference there. And obviously, continuous flow pumps have slightly better results. We know all of this. And if you look at the different age groups, it's even more remarkable. If you look at those ones, nobody would touch those in the UK anyway. Well, neither for transplant nor for anything above 70 years of age. But if you look at the results, they're actually the same. There's no difference. If you're above 70, you have the same good outcome compared to somebody who's much, much younger than you. Obviously, we've seen that before. Andre has shown this. It depends on the severity of the disease at the time of implant. That's just not rocket science. Now, let's look into transplantation. So we know transplantation has a 20 to 25% early attrition rate. So 20 to 25% of patients die early on, which makes it the highest risk surgical procedure in the armamentarium of cardiac surgeons. Okay, just remember that. And regardless whether you have a VAD or you don't have a VAD, even if you have a virgin chest, you have a risk of 20% to die within the first 3 months. So just make sure your patient is aware of this. So, let me just... This sounds okay, because everybody's saying how wonderful the results for transplantation are, but if you break it down into patient group with different risk factors on top of their cardiac disease, then it looks quite different, because if you look at the smokers, you look at the smoker, diabetes, history of peripheral vascular disease, etc., etc. All this adds up to the overall risk, and then this risk will then increase your overall, reduce your overall outcome. If you look at the Intermax registry again and look at different risk factors for destination therapy patients, and there's the obvious culprits you find again: Intermax classification, RVAD, history of cardiac surgery, dialysis, etc. These are high risk factors for worse outcome as compared to a patient who had no risk factors. So if you compare this now, if you put this into a graph and you take a typical 2-year mortality after heart transplantation, it's quite an elegant slide actually, and put this as a straight line, and you add up the risk of a patient of the destination group. He has a low profile, overall risk factors, BMI is normal, no CVA, no history of previous cardiac surgery, etc. You can see you have to go up to the age close to 70 to get above the mortality risk of a transplant patient. So quite good, not bad. And if you can break this up into a Kaplan-Meier and go through low risk, medium risk, and high risk patient, you can see that there is a 80% 2-year survival if you have a low risk patient who might be 70 years of age who has an LVAD, which is a remarkable result, and basically is way, way better than any of the transplant databases. Obviously, there are other risk issues to be considered, and Andreas Zuckermann has pointed out that there's you have to think about the risk of stroke, infection, right ventricular failure, pump malfunction, etc., etc., etc. We're still at an early stage. This is all to be managed. And particularly in the UK, we're probably 10 years behind in building our programs, which has to be accepted, whether we like it or we don't like it. If we don't like it, we have to leave the country. This is the situation. We have to work hard to make things better for our patients, and we do that day by day. And obviously there also has to be an analysis of the quality of life, functional capacity, acceptance of the patient, and ultimately costs. But if you look at the Kaplan-Meier again, looking at different pump-related events, it's not so bad. It's actually fairly constant for the continuous flow pumps, and much better compared to the pulsatile, which is expected. And there's some quality of life analysis, which obviously shows some improvement. I'm not sure this is validated enough to be presentable. I'm not an expert in this. And obviously, if you embark the program of potential destination therapy, you have the potential for recovery. I talked about it briefly before. In Harefield, Andre's group, they have made their name basically to demonstrate this. This is quite effective. If you treat the patient well and you look for it, you have a chance for recovery. And again, this avoids heart transplantation. And obviously there are new developments, technical developments in the pipeline which do not exist in heart transplantation. The procedure is the same as 25 years ago, and there has been no recent improvement in technology, medication whatsoever in heart transplantation. Whereas here you have, for example, this is a model which we will be using in the future where you can avoid driveline. It's transcutaneous energy transfer, the patient just wearing a belt and does the same thing as the driveline does. So some summary points. So long-term LVAD support saves the life of patients not eligible for heart transplantation, no question. Destination therapy currently accounts for the primary strategy in more than 40% of approved device implants in the US. Patients over 70 years that are selected for VAD therapy appear to enjoy survival similar to patients aged 65 to 70. Among destination therapy patients in level above 3, in other words, absence of acute cardiac decompensation, nearly 20% have an expected survival of 80% or more at 2 years. Quality of life indicators suggest sustained improvement. Measured of overall burden of adverse events will shape the comparison of this therapy with others, obviously. So what is the situation outside the UK concerning this? There's major US trials in preparation, which will start this year. There's at least 3 going. And we in the UK, we have to be sure that we're not left out of the development. I think that's a crucial point for us, is to keep track with what is happening outside. So the conclusion is basically Based on present scientific information, it has to be regarded as unethical to deny LVAD therapy to non-heart transplant recipients. A UK rematch 2013 trial could give additional information on quality of life and costs comparing state-of-the-art medical management versus the latest generation MCS. And I'd just like to conclude with this one here, which basically, again, the gentleman on the right probably looks familiar to you. It's Dick Cheney, who received a HeartMate 2 at the age of 72 and then got transplanted, which he wouldn't have had in this country. He would have passed away, although he might have, if he was the Prime Minister, he might have actually got it, but he didn't. So he's successful with his HeartMate 2. This gentleman, though, is more interesting. He's a gentleman I went to help implant a long-term LVAD. He's 75. He's ischemic cardiomyopathy, Israel. He's a senior member in the kibbutz over there. And I went down to help them to put an LVAD in at the age of 75. So he went home shortly after his implant, no problems whatsoever. This is his most recent anniversary, so now he's 78. He's in charge of the water system and the car park of the kibbutz. He's organizing this on his computer, and he's absolutely spot on. He said he has never had such a good quality of life as he has now. So I think that's a good take-home message for you to think about destination therapy. Thank you very much for your attention.
Couldn't agree more. So any comments or questions? Yes.
Inevitably, I think some of your data was from that Kilich UNOS analysis, where they showed that 58% of transplant patients don't reach 10 years. And for that 58%, the average survival is 3.7 years. And then Kilich put out another paper about risk factors for transplantation that showed the metabolic risk factors for ischemic cardiomyopathy were the ones that made the patients do badly. So in other words, cardiac transplantation is not a great treatment for people with coronary artery disease and metabolic risk factors. And I think it's quite clear now that everywhere else, the primary treatment for New York Heart Class 4 heart failure, just in terms of symptomatic relief, is either a VAD or palliative care, which shortens life and kills the patient. So the essence of getting this accepted now is to put that into the public arena. Because if you're 65 with end-stage ischemic cardiomyopathy and you can either have a device and 5 more years of life, or you can have morphine and have your funeral in 3 weeks' time, the patients need to know that that is now an alternative.
Well, I kind of disagree with you, Steve, because I think we're coming to the same conclusion, but I think the way to get there is slightly different. Living in this country now for almost 12 years, I think you can't change too many things at the same time. So when you want to change the commissioner's thinking, allowing us to do more, particularly despite the fact that we're saving the patient, but also we have to keep in mind to develop our programs. And we have to help smaller programs to get bigger, to develop other centers, to embark on the idea of mechanical circulatory support. That's our mandate, because only if we do that, we will win at the end. If we do everything at the same time, if we suddenly start questioning the concept of richer transplant for certain subgroups of patients, it will completely fall into a disaster. My strategy is slightly different. I try to identify those borderline patients. Try to identify the borderline patients, which is a substantial group. It's not a huge group, but it's not a shockingly huge group for those who give me the money. But it's a group which we can work with. And if we demonstrate good results, better results than Andre has shown, which are part of the learning curve, then we might win. Then we might open the door for a broader application and no restriction on bridge to whatever.
But you can't go back to a UK rematch trial because that is absolutely unethical.
I'm not sure. I'm not sure.
Before you discuss this, I think Andre has
Yeah,
one
sorry.
question.
Time is up.
And then we
Would you
have a
not-
break.
Would you, I agree with basically everything you say, and then I disagree again. Would you not, on the current situation where we have roughly 100 transplants going on in the United Kingdom, and we have this therapy available, should we not actively go out and say we should limit heart transplantational activity to those who have a certain profile and benefit? We should not pretend that we can successfully bridge to transplantation in everybody, and we should make this therapy available for those who will clearly benefit from them, and not just the fringe group. I know that might be a politically good way to go forward, but quite frankly, we still have patients on our waiting list who should, by all means, be implanted with a ventricular assist device today, end of discussion when you look at the medical data, and we could send them home, but we keep them on the waiting list and we wait until they deteriorate, and then we either transplant them or we put them on a ventricular assist device in the end with a bad result. Do you not think that we should go out, take that step and say that therapy must be limited, increase numbers, but that therapy has come of age and should be there?
Yes and no. I think we have to remember, despite all the enthusiastic approach, everything we do is palliation. We don't cure. Okay, palliation. So what we do, we expand lives. If we expand it for 5 years, fine. We might for some we might expand it forever, like Steve with his young lady who recovered after his ECMO, but not for everything. So we can't save everybody. We have to take it stepwise. And you go to your hospital, you find your patient, and you do what's best for that particular patient. I agree. We should do that more often, and we have started this discussion. We took a lot of heat in Newcastle for this, and we still do. So, but this is. I'm convinced about this strategy. I'm not putting any artificial limits on anything. What I like to do, I'd like to treat heart failure as appropriate as possible, with different measures. I don't care what I'm going to use, as long as it's successful. That's my personal view.